Every hour, a modern hospital generates thousands of independent data points. Patient vitals, lab results, and pharmacy orders constantly flow across entirely different departments. Historically, facilities tried to manage this with an electronic medical record, or EMR. This is a digital reflection of a traditional paper chart, with data stored and managed entirely within the walls of a single healthcare entity. The industry relies on the electronic health record, or EHR, to bridge these gaps. The EHR is a broad system built to conform to national interoperability standards, allowing authorized clinicians to consult data across multiple separate healthcare organizations. The ultimate goal of this interconnected network is the construction of a longitudinal health record. A longitudinal record is a permanent, chronological log of a patient's medical history. It captures clinical and administrative data continuously over time, from birth to death, regardless of where the patient receives care. The EHR provides the functional infrastructure required to track a patient's journey across the healthcare ecosystem. This block diagram shows an EHR is a composite of multiple specialized systems working in tandem. It takes years to implement, managing several distinct operational quadrants at once. Raw data first enters the ecosystem through the source systems, including clinical wings and administrative departments. Within these source systems, the Registration, Admission, Discharge Transfer System, the RADT, serves as the administrative bedrock. It collects patient demographics and routes the insurance logic necessary for financial services. Active medical intervention and documentation occur within the core clinical systems layer. A functional EHR synthesizes these inputs instantly. It merges the administrative constraints of a patient's insurance with active clinical findings from the lab, packaging the results for the physician in real time. We can see this synthesis in action by tracking a single physician order. Imagine a doctor prescribing medication to a patient with a complex history. This is a sample screen of a computerized provider order entry, or CPOE system. It is the primary interface for the physician's action, functioning as an active filter for every order entered. The CPOE's intelligence relies on the clinical decision support system operating in the background. As the doctor types the prescription, the CDSS uses rule engines to actively cross-reference the order against the patient's allergies, current medications, and insurance formularies. It validates the decision before the order is transmitted to the pharmacy. Once cleared, the order moves to the Electronic Medication Administration Record, or EMR, which is accessed at the patient's bedside. To close the loop, the EMR system uses RFID microchips, or barcode scanners. The nurse scans the patient's wristband and the drug itself to verify the 8 rights of medication administration, ensuring the right patient receives the right drug at the correct dose and time. These integrated safeguards validate medical decisions at the point of capture, transforming the record into an active mechanism for preventing clinical errors. Internal data routing works efficiently within a single facility. However, transferring that curated data to a different hospital system requires clearing several technical hurdles. Systems rely on interoperability to move data outward. The industry breaks this process down into 4 strictly defined levels. Level 1 is foundational, establishing the basic interconnectivity to securely send and receive data. Level 2 is structural, defining the specific format and syntax required for data exchange. Level 3 is semantic interoperability. This level provides common underlying models, so completely different vendor systems share the exact same vocabulary and meaning for every data element. Level 4 is organizational. This layer handles the legal policies, governance, and shared trust required for data to move between competing entities. Standards developing organizations like Health Level 7 International, or HL7, create the protocols that allow systems to clear these hurdles. Their FHIR standard provides the modular components used for cloud communications and mobile app data sharing. Without semantic translation and organizational trust, patient data loses medical context the second it leaves the source hospital, rendering it useless to the receiving physician. This bar chart outlines the percentage of non-federal acute care hospitals using certified EHRs. We see high adoption rates, ranging from 93% in rural hospitals to 99% in large organizations. A paradox exists within these numbers. Despite high adoption of certified systems inside hospitals, external health information exchange between competing providers remains low, with only about 60% of hospitals actively exchanging data. The primary cause of this friction is health information blocking. Information blocking occurs when vendors or providers knowingly implement products in non-standard ways to make data retrieval difficult. This practice protects proprietary business interests by locking patient data within a specific vendor's ecosystem. The persistence of information blocking to protect market share stands as the primary obstacle to a unified national health record. To break these data silos, the federal government spearheads compliance through the Office of the National Coordinator for Health Information Technology, or the ONC. The ONC mandates the use of certified EHR technology, or CEHRT. By tying these certification criteria directly to Medicare reimbursement programs, like the merit-based incentive payment system, the government incentivizes interoperability. This flowchart illustrates the strict regulatory pipeline an EHR vendor must navigate to achieve mandatory certification. Before deployment, software is tested by an accredited testing laboratory to meet technical standards, only then receiving final approval from an ONC-authorized certification body. Certification is an ongoing process. Vendors are subjected to continuous market surveillance to verify their software maintains its capabilities in the real world and that they are not falsifying compliance. This immense regulatory and technical apparatus ensures that critical, accurate data reaches the physician at the exact moment of care. Modern EHRs successfully organize patient data at the local level. Realizing the ultimate promise of true population health requires dismantling the final walls of these information silos.